So I'm William Beardsley, a co-chair of the forum, and I'm not going to spend the 20 minutes that it would take to adequately introduce Richard Frank. Richard Frank is the Associate Secretary for Planning and Evaluation, Health and Human Services. Here we are at the Institute of Medicine, founded with the idea that science would serve the public interest, signed into law by Abraham Lincoln in 1863. Dr. Frank's career has exemplified those principles. He's been an extraordinary scientist and economist. He's been an extraordinary policymaker and a friend, advisor, and someone who's taught me a great deal. We've both worked at Harvard in Boston. And he's had two stints, the current one and one previously, in the administration, specifically to try to bring his extraordinary knowledge of economics and mental health into the policy arena. He'll give our keynote, and then we'll break into discussion groups. Richard.
Thanks very much. It's really a treat to be here. There are old friends in the audience, there are dear colleagues, and there's even an ex-squash partner in the audience, David Brent. Is Brian still here? No. Okay. Well, when I was putting my talk together, I was when I agreed to do it, I was still a professor at Harvard, and in the interim, I got confirmed by the Senate. And so I went running around the other day at HHS saying, gee, who do I need to give this to get cleared? And I found out that the answer was nobody. And I'm now convinced that the reason for that is that after 15 months of vetting by the White House and the Senate, I'm no longer capable of saying or even thinking anything controversial. So, so here we are. So Bill Clinton made an observation that's really apropos to today's discussion, which is that we know a lot about what needs to get done. We just don't know how to do it at the right scale. And his admonition was figure out what works under what conditions and then scale it up. And I think that is a lot of what we're going to talk about. I'm going to make, and there are a lot of components to figuring out how to scale things up. I'm only going to talk about the ones that are primarily focused on financing and incentives. But first I'll start off with just some general observations about scientific success at scaling and the basis for optimism. Then I'm going to talk a little bit about some of the policy changes that have occurred recently and the opportunities for the behavioral health field and prevention in particular to do more and to do better. And I'm going to run through some of the issues around insurance reform very quickly, and then I'm really going to sort of focus more specifically on delivery system reform incentives and how they relate to prevention, and then I'll make some concluding remarks. So I am, after all, at the IOM, so it's important to give credit where credit is due, and especially when Bill Beardsley is introducing you, it's really important. And so, yes, there's been scientific success, and I think the opening comments by Mary Jane really sort of emphasize just in sort of quantitative terms just how steep the rise has been. What I want to do, and some of that can be credited to advances in sort of our ability to do research, others into sort of ingenuity in designing programs, and advances in neuroscience as well in our kind of understanding of childhood development. Now I want to identify what I call three buckets of, quote, prevention and early intervention for the sake of policy and the comments I'm going to make. The first one is clinical preventive services. And those are services that look a lot like what we do in healthcare generally, but usually are not attached to any particular diagnosis. And so they're prevention, but they're prevention using the tools of standard healthcare. The second one is early intervention, which is the bottom one there. And early intervention fits even more comfortably into the way we pay for insurance today, which is their services that largely look like medical services or healthcare services, and they come with a diagnosis, but they intervene at a particular point in the course of illness so that it attenuates the bad effects. And finally, there's traditional public health. And the examples I always think about are sort of the Baltimore Prevention, Your Game, Triple P. Those types of things are services that reach well beyond what is considered health care and are not necessarily paid for using mechanisms that we use to pay for health care. And that is going to be a kind of a different kettle of fish. And what I'm going to do is walk through my remarks, and I'm going to try to tie the various changes that we've made to each of those three buckets. So this is a sort of a summing up of all the nice comments that Kelly and Eric made on this point, which is if you look at Mary Jane's listing of evidence-based practices, if you looked at the little set of examples I just put up for you, you'd be pretty optimistic that there's stuff we know how to do, we know how to do it well, it's been tried repeatedly, it's worked, and nevertheless, what we see is really slow diffusion. Does anybody remember when David Olds did his first study, his first trial? 1982. What year is it now? Okay. Slow diffusion. Second, scaling is tough. I think that each of the speakers that preceded me sort of made that point in one form or another. And so the result is that we have lots and lots of programs and interventions. And the problem to me isn't so much that we have a lot of ways of anointing them, even though I understand bureaucratically why that can become a problem. The much bigger problem is that they wind up still as little boutiques, right? We shouldn't be hanging around the mall as much as we are. We should be hanging around Walmart in this area. And it's really a matter of how do you turn these little boutiques into Walmarts? Okay, let me turn to the new opportunities. And they come in two forms. The first is bringing new resources in through expansion of insurance, both public and private. And as you know, the Affordable Care Act expands and restructures private health insurance markets. It also expands Medicaid in some places. And then prior to that, in 2008, was the Parity legislation. Together, they bring a lot of new resources into the behavioral health area, and that's important. The second form is what I call delivery system reform, which brings new institutions and new incentives to do new, and brings them together with the new resources. And it's really the two of them together, but they have different effects. And most of you know a lot about Parity and the Affordable Care Act's insurance expansion, and so I'm going to cover that really quickly, but just still try to touch on it, and then I'm going to turn to delivery reform. Okay, so Paul Wellstone, Pete Domenici, and the Parity legislation was passed in 2008. A cocktail fact for all of you, that the TARP, the Asset Relief Bill, passed because it was attached to the Parity legislation, okay? So in fact, not only did we improve mental health in this country, we actually saved the entire economy. But the Mental Health Parity Act was limited to firms that offer behavioral health coverage. So it was not a mandate. It said that if you offered behavioral health care coverage, it had to be on par with medical surgical. And it was also limited to firms with 50 or more employees. What the Affordable Care Act did, and again, this is a very touching picture. Do you all recognize the person in the lower right-hand corner? That's John Dingell, who, if you recall, his father worked with Truman to introduce one of the first national health insurance bills. And so it's actually quite touching that he was sitting right next to the president at the signing. At any rate, what the Affordable Care Act does is it includes mental health and substance use services, disorder services, as part of the essential health benefit, which what that does is it makes mental health and substance abuse treatment a mandate. It mandates them. And then it requires that they be done at parity. So the combination of the parity statute and the Affordable Care Act's essential health benefit essentially makes creates mandated behavioral health benefits on par with medical surgical benefits. And so that's important. So that just graphically highlights the issue. So what is the impact? Well, the impact is that we get about 30 million people when it's all rolled out that will have behavioral health care coverage that they didn't have before. And another 30 million people that had behavioral health coverage, but that will improve. So overall, it's about 61 million people have had their coverage changed because of the Affordable Care Act. There we go. Okay, let me now turn to delivery system reform. And as I emphasized a second ago, delivery system reform is about two things. It's about new institutions, and then it's about changing the way what I guess Kimberly called the financial hydraulics work in those institutions. So some of the ones you've probably heard about, Kelly mentioned accountable care organizations, Medicaid health homes are focused on the sickest people, but have a particular emphasis on behavioral health. The Innovation Center is creating a variety of new programs, including bundling, patient-centered medical homes, and then there's the Prevention Fund. Okay? So each of those is a kind of a new structure, a new institution that is supposed to deliver and organize healthcare somewhat differently. Let me talk about the philosophy for a moment that sits behind those, which is the concept is to take more services and more dollars and put them under a budget and delegate the management of that budget to clinical organizations that have broad capacity to manage the continuum of healthcare needs. Okay? And that does not mean that it eliminates things like managed care organizations or anything like that, but it sort of shifts the emphasis away from fee-for-service and insurance-based designs more towards budgeted systems that still have an insurance component but are run by clinical organizations. And what goes along with that philosophy is high-powered economic incentives that do two things. They reward organizations that can save money, that can do what they did, in fact, do more than they did before for less budget dollars, and it does so by requiring that certain quality conditions be met before you can collect the goodies. So, high-powered financial incentive. When you put a budget on people and you tell them that they can keep some or all of what they save, you're creating strong incentives for them to do less. Okay? Now, that often worries people. It should. balancing against that is the idea that you don't get to collect those economic benefits until you've met clinical standards, quality standards. And so this, in theory, can favor prevention and early intervention approaches. If, in fact, what many of you have been saying all morning is even half true, then what you should be able to see is organizations investing in prevention, taking the flexibility of owning the whole budget and not worrying whether something is payable by Medicaid or payable by Medicare or payable by private insurance, because it won't matter anymore. You're being given the whole thing, and you're being held to a set of standards around quality, outcomes, and the like. And so, in theory, you'd expect these new organizations to use that flexibility to invest in preventative services because they, according to some evidence at least, pay off. Now, the challenge is that the business case relies on savings after meeting quality standards. And in behavioral health, as we've already heard, the quality standards are really in their infancy. Moreover, because, in fact, the philosophy of modern health reform has adopted what I'd call the Kelleher conjecture, which is that none of this is going to work unless you have integration. Well, that means you have only a handful of measures you can possibly implement that cover behavioral health, because in fact, what you have is cardiovascular and pediatric and oncology outcomes that you have to track as well. So not only do you need to have good measures, but they have to be targeted in such a way that they pick up a lot of different stuff, that they're correlated with a lot of different things. Okay, now, everything I've said up to this moment touches on two of those buckets that I was telling you about at the beginning, the clinical preventative services and the early intervention services, right? Those things are animals that are produced by healthcare organizations, and they know how to do them, they know how to count them. Their systems are all set up to manage those. The incentives to do the kinds of things that we call public health interventions, which, if you go back to Mary Jane's opening comments, are tie into social welfare, tie into housing, tie into juvenile justice. The incentives to do that are much weaker under these new organizations, because you're asking people not only to use dollars that are based on healthcare accounting, but you're asking them to go way beyond their traditional areas of expertise and areas of touch. So what we rely on, therefore, are traditional public health institutions, mental health agencies, SAMHSA block grants, public health departments, and the like. And the political economy of those budgets is quite different from what I've been talking about on the Affordable Care Act, which is, at this point, there's such skepticism in this country about the usefulness of public spending in general that the bar has been set very, very high. In fact, it's been set so high that lots and lots of interventions that are not only cost-effective but cost-beneficial, that is, socially efficient, are left on the drawing board because of skepticism about the way government spends money. Are there any economists in the room besides me? Boy, that shows you the kind of organization this is. You bring in one and that's it. Okay, anyway, what this just means is that the price, in a sense, that we put on outcomes for government spending is way higher than we do on average in our society, right? So you do the cost-benefit analysis and you say this thing's efficient. Government might still not fund it because it's not efficient enough. It's not good enough because their standards are so stringent. Okay. Part of the reason that this happens is because public mental health, in this case, budgets, have taken a hit. And they've been taking a hit for a while, but they've been taking a really big hit since the start of the Great Recession. And so this just shows you the negative flows. And these are not after inflation adjustment. These are nominal. So these are absolute just dollar decreases. So the point is there's a huge amount of stress on public health budgets and public mental health budgets in particular, and therefore that contributes to causing that bar, that cost effectiveness bar, to get raised higher and higher because those dollars are becoming scarcer and scarcer. So, so how do you go after those public health programs? What are the hopes that we have for doing a better job paying for those? And you're probably somewhat familiar, and Kelly and Eric both talked a little bit about what I call pay for performance or performance contracts. And so I'm not going to focus on those because those are better known. I'm going to talk about pay for success, or so-called social impact bonds. So social impact bonds are a new idea, and they really have their recent roots in the criminal justice arena in the United Kingdom. And for the last 3 budget cycles, President Obama has put in a proposal to put some significant dollars, like $100 million a year, into social impact bonds. When those budgets haven't exactly seen the light of day, they've managed to actually scrape together some funds to have sort of a starter fund of like $10 to $20 million a year to get some of the initiatives going. And so you see them in the Department of Labor and the Department of Justice, and starting to show up in HHS. Now, the idea behind the social impact bond is quite simple. It's how can we figure out a way to bring new dollars into the system that are private dollars, and do it in a way where government will continue to participate, to continue to make their commitments, but do so in a way that's more acceptable to the political economy in a state or in the federal government. And the idea is to get the private investors to pay for the upfront costs of new programs, to get them to invest in those upfront costs, thereby shifting risk away from federal, state, local governments, and then paying out based on outcomes, returning to the investors their original investment plus a rate of return above that based on the achievement of particular outcomes that are socially desirable. And so a typical outcome would be, a combination of 2 things, much in the same light that accountable care organizations operate, which is some programmatic outcomes along with savings. Okay? And some of the places where it's being tried in the behavioral health prevention area are nurse home visitation programs. There's a social impact bond effort underway there, child abuse and neglect prevention, and then targeted pre-Ks. So here's a schematic of how it operates. There's generally 4 parties to the deal. There are the investors that are at the top there, the private investors, and what they do is they fund the interventions, but they're also serves as an evaluator a little bit, because they're not going to put their money in unless they believe the thing's a pretty good bet. So that gives you another level of accountability. The government is a participant. The government says, if in fact this program gets up and running and meets its objectives, we will pay for the cost of the program and enough for the cost of the program plus a rate of return to the investors. Okay? Then we have the nonprofits or the usual set of characters that provide the actual services. And then the whole thing is coordinated by an intermediary that essentially brings all the parties together. It organizes the investors, it gets the commitment from the government, it holds the money, it measures the outcomes, and then at the end of the day, if successful, it pays out. Okay, so you can see why this is potentially attractive. Maybe. One, it brings new money into the system. Two, from the political economy standpoint, it takes the government out of the startup thing. And the government's now only paying for things that work. So politicians like that, public servants like that. It pays out for results, so it continues to shift the paradigm from service-based funding to performance-based funding. And it creates new accountability because you have two forms of accountability. One, you're paying on the outcomes. Two, you're not even putting the money in until some investors are convinced that this thing's a pretty good bet. Now, there are some downsides. First of all, many of the things, in spite of the claims that have been made here this morning, there are lots of prevention programs that don't pay off quickly. And the question is, what can you do about it? Now, it's not hopeless, but it just makes the whole thing a lot more complicated, right? Nurse home visitation program pays out by keeping people out of jail when they're 17, 18, 19, 20. That's the big payout, okay? But the investment is made, right, in the womb, and then in the years shortly after that. So you need to figure out how you're going to kind of capitalize that. Second, this particular form of risk-bearing, we don't know how attractive it is to investors. And one of the concerns is that some of these things are really risky, right? If any of you, when you look at your studies, right, you guys are thrilled with a p-value of 0.05. You know, hooray. Your variance might still be pretty large, and therefore there's a lot of risk to investors. So they may not love this, and the question is, are there clever ways to create tranches of investment so that the private investors perhaps get some of their risk buffered by things like foundations and things like that. So that makes things a little more complicated. And finally, this is in the really early stages of development. And so we don't know exactly how well it's going to work, you know, and on what scale we're going to be able to raise it on. On the other hand, there's a lot of experimentation going on right now, and there's a lot of enthusiasm for it. So let me finish up by saying, first of all, there are a lot more resources available for clinical preventive services and early intervention services due to the coverage expansions, parity, preventive services rules, and also the new institutions. Now, the new institutions and the incentives that come with them are creating an environment that's a lot more hospitable to integration and early intervention of preventive services. And so that's a big plus. So the two of those things together should make us optimistic for at least two pieces of the pie: clinical preventive services, early intervention. We have new institutions, new resources, new money, new opportunities for our least fortunate citizens to actually collect on those things. The environment for traditional public health interventions is a very tough one. But there are lots of people actually putting energy and thought, and there's foundations, and the federal government are actually trying to do things to jumpstart some creative solutions to that. The worries in sort of doing all this are, can we get the metrics so that in fact the promises of the new institutions pay off? Because It's advantageous to pay attention to behavioral health outcomes rather than to ignore them. Always a risk. Second, can we reach out far enough into the public health system using sort of some of these new innovations that allow us to go beyond things that have quick, immediate payoffs for big savings. And I think getting creative, getting smart, and experimenting with those things is really the challenge going forward. So thanks a lot.